My name's Sarah. I work for the Nottinghamshire Alliance Training Hub. I'm delighted today to introduce Mohammed Akram, who is a cardiology pharmacist working for Nottingham West. I'm going to hand over to him now and let him introduce himself.
Hello, everybody. Thanks for joining us today. The plan is to give you a quick overview of hypertension. Like Sarah said, my name is Mohammed Akram. I work for PICS in Nottingham West as a cardiologist pharmacist. We've set up a team of cardiology pharmacists and technicians over the last 2 years, which takes in referrals for hypertension and lipid management. And today's agenda, so we're going to cover the diagnosis and management of hypertension to prevent cardiovascular disease, look at the overview of the latest NICE guidelines to manage hypertension, and any questions at the end. So why focus on hypertension? Because I think we can screen for it and it can be managed. Hypertension is, in the UK, is the third biggest risk factor for premature death and disability after smoking and poor diet. And for every 10 people that we diagnose with high blood pressure, there are further 7 people that remain undiagnosed. In terms of diagnosing for hypertension, so according to NICE guidelines, it's recommended that we check the blood pressure in both arms, and if the difference in blood pressure is more than 15 millimeters per mercury, then repeat the blood pressure, and if the difference remains more than 15 millimeters on the second measurement, then any subsequent measurements should be done in the arm with a higher reading. If the blood pressure measured in the clinic is 140/90 or higher, then a second measurement should be taken during the consultation. And if the second measurement is substantially different from the first one, take a third reading and use the lowest of the 2 readings as a clinical blood pressure. This is to account for the fact that patients can be having sort of white coat hypertension. Patients don't sort of live in the surgery, so if there is a raised clinical blood pressure, then we should offer them blood pressure monitoring at home. So looking at the sort of NICE guidelines, this is a sort of 2-page document which I use quite a lot, and it's a summary of diagnosis and treatment of hypertension. We can see that there's 3 sort of stages for clinical blood pressure measurements. So if the clinical blood pressure is under 140/90, then that's considered as sort of normotensive, and it's recommended that the patient checks the blood pressure every 5 years, or more often if it's closer to 140/90. If the blood pressure at the other extreme, i.e. very high, that's 180/120, then there's a criteria that's been established for same-day specialist referral, and this I will go over a little bit further on in the presentation. If the blood pressure is between 140/90 to 179/119, then we should offer them home blood pressure monitoring, and the preference is for ambulatory blood pressure monitoring over home blood pressure. But if the ambulatory is not appropriate, or you can't do it, then home blood pressure is still very effective compared to just using the clinic blood pressure alone. So just a bit about white coat hypertension. So white coat can lead to an artificially high clinic blood pressure readings. NICE recommends that ambulatory blood pressure monitoring is used to rule out white coat hypertension, as there is evidence that indicates it's most accurate for diagnosing hypertension. If it's not tolerated or declined, then we can offer home blood pressure monitoring. Like I said, ambulatory blood pressure monitoring is the gold standard, so we should always offer that first. But to make sure that it is effective and within the guidelines, we need to make sure that there's at least 2 measurements done per hour during the person's usual waking hours, and then use the average of at least 14 measurements taken during the person's usual waking hours to confirm the diagnosis of hypertension. Ambulatory blood pressure monitoring also screens for AF as well, and if it does sort of highlight that there's potential AF, this needs to be followed up with a 12-lead ECG to confirm AF. I've used a lot of ambulatory blood pressure monitoring in the last year, and one of the useful things we found is that community pharmacies can offer it as well. And if you set up good relationships with them, it can be an avenue to sort of share the workload, because there can be limited number in GP practices. It's also quite interesting to see the difference in blood pressure readings of day and night. Although it's pointed out, NICE guidelines recommend you using the daytime measurements, but you do find that some people's majority of people have low sort of blood pressure at night, but you do find the opposite sometimes as well, where it's high at night and low in the daytime. In terms of home blood pressure monitoring, we need to make sure that there's 2 consecutive measurements done at least 1 minute apart with the person seated. Blood pressure should be done twice a day, that's morning and evening, and minimum for 4 days, but ideally for 7 days. When doing the average for the home blood pressure readings, you shouldn't include the first day, so start your average from day 2. And I work across the PCN, and it was found that some surgeries were doing this and some weren't doing this, so it's worth checking what's actually happening when calculating the average. In terms of investigations recommended by NICE, we need to assess the cardiovascular risk, so that and these investigations sort of help identify diabetes, any hypertensive damage to the heart and the kidneys, or secondary causes of hypertension, e.g. renal disease. So the following tests should be offered: blood tests for HbA1c, UNE, creatinine, EGFR, total cholesterol, including HDL cholesterol. Should offer a 12-lead ECG, an ACR, hematuria using dipstick, and examination of the fundi for hypertensive retinopathy. A lot of my consultations are done over the phone, and we quite often recommend visiting the optician for the fundi examination. Now, I put this in because we were doing a little bit of work around this, and we've managed to get it on the common profile. So if you were to, when you're booking for bloods on ICE, if you go to the common profiles, there is a sort of link for hypertension bloods, which will bring up the bloods needed for a patient. So people might find that useful. So once the patient's done the blood pressure readings, looking at the results, if the results come back and the home blood pressure readings or ambulatory blood pressure readings are less than 135/85, and it shows that there was sort of white coat effect within clinical setting, and it's recommended that blood pressure is checked at least within 5 years, or more often, depending on how sort of, if it was close to 140/90. If evidence of target organ damage, consider alternative causes. If it's identifying stage 2 hypertension, that is blood pressure of 150/95 or more, then we should offer lifestyle and medication. And if the patient is under 40, then we should consider referral to secondary care for any underlying causes of hypertension. In sort of the middle stage 1 level, 135/85 to 149/94, the medication depends on the blood pressure, the age, any organ damage, and the 10-year cardiovascular risk score using QRISK 2 or 3. So looking at this, if the patient's over 80, the treatment threshold for is blood pressure of 104 over 104, 150 over 90. If the patient's under 80 with target organ damage, cardiovascular risks, or renal disease, diabetes, or 10-year cardiovascular risk score of greater than 10%, then we should offer lifestyle advice and discuss starting treatment. In terms of looking at the 10-year cardiovascular risk level, so in terms of looking at the 10-year cardiovascular risk at 10%, it is shown that at stage 1 hypertension, if the cardiovascular score is at 10% or more, it's cost effective to treat these patients with medication, i.e. it's cheaper to treat and manage the blood pressure and the consequences of heart attack and stroke. But thinking about at what 10-year cardiovascular risk does it become cost effective to treat patients? So if the Q risk is less than 10%, is it still cost effective? So it was found that for both men and women, if they have a Q risk score of around 5% and they're under 60, it was still cost effective to recommend treatment. So that's why there's new sort of stage here where if a patient is under 60 with 10-year cardiovascular score of less than 10%, should offer lifestyle advice and consider drug treatment. So also looking at patient decision aids. So this helps patients understand what hypertension is, what their options are, and give them information about medicines, side effects of them. And it's a really useful tool to send to patients while sort of you're doing investigations, etc. It doesn't replace sort of the full information, etc., but it's a really useful tool, so I always use it. When considering choice of the drugs, so I'm just going to go through that with you now. Discuss with the patient their individual cardiovascular risk disease, what their preferences for the treatment is, including no treatment, and explain the risks and benefits before starting the antihypertensive treatment. So patients with type 2 diabetes or patients under 55 and not of Black, African, or Caribbean family origin, it's recommended at stage 1 to offer ACE inhibitors such as ramipril or ARB such as losartan. On the other side, if the patient is over 55 or of Black or African Caribbean family origin, then we should be looking at calcium channel blockers such as amlodipine. Normally start at low dose and work upwards depending on blood pressure control and how the patient tolerating the medication. At stage 2, we can see that the guidelines have been a little bit more relaxed. So if it gives you kind of a choice of various things, and it's more about blood pressure control and not about which medication is used. So it's the medication that patient is most likely to take, that's going to be the most sort of effective. And at stage 3, it's just adding in that missing medication. So just covering on this side bit here that in terms of guidelines for measuring, so it's also recommended to measure postural for any postural hypertension in people at risk. So this is when people's blood pressure is lower when they stand up compared to sitting down, and those at risk are type 2 diabetes. We can also, although not mentioned here, but we can also consider type 1 as well. People with symptoms of postural hypertension and anybody over the age of 80. The other sort of things to also think about could be patients on alpha blockers such as doxazosin. If they do have postural hypertension, then use the lower blood pressure on standing for blood pressure treatment. targets. This is based on sort of safety reasons rather than evidence-based, as the patient's at risk of falls and fractures. In terms of blood pressure targets, so if we're looking at patients aged under 80, the clinical blood pressure, we're looking for it to be less than 140/90, ambulatory or home blood pressure less than 135/85. If they're over 80, then the treatment threshold is or less than 150/90, and ambulatory blood pressure less than 145/85. So there's a couple of things that's also quite useful to look here is that there's kind of notes added here, 2 and 3. So looking at note 3, it's an MHRA alert, which says that you should consider ARBs in preference to ACE inhibitors in adults of African Caribbean origin, because ACE inhibitors are associated with increased risk of angioedema. And also looking at the note of 2 is that considering women of childbearing age, so obviously there's a MHRA drug safety alert on ACE inhibitors and angiotensin renin inhibitors, not for use in pregnancy, and if that is the case, then you should refer to the NICE guidelines on hypertension in pregnancy. So coming to stage 4, so at this stage, we should confirm if the hypertension is still in control, then we should confirm whether it is resistant hypertension, whether it's rule out white coat hypertension. So we should offer AMBP or home blood pressure monitoring, and also in terms of options, we could either refer to secondary specialist secondary care for review, or we could add in low-dose spironolactone if the potassium is less than 4.5. In terms of potassium, if we are using it, it is slow to act. It can take 2 to 3 months to show sort of results in lowering blood pressure, but it is very effective. If the potassium is more than 4.5, then you can offer them alpha blocker or a beta blocker. So referrals to secondary care, they will offer screening for the patient for any underlying causes such as renal artery stenosis or hypoaldosteronism. In terms of diet and lifestyle changes, so various things sort of to look at is weight loss. So it's shown that a loss of 10 kilograms can have an impact on lowering the systolic blood pressure by 5 to 20. In terms of dietary changes, so again, it shows you the benefits that can be done on there, 8 to 12 units. Salt intake, we recommend having salt less than 6 grams a day. And just looking at sort of, there are packaging, etc., on the products patients buy that highlight like a traffic light to show how much salt is in there. 6 grams is about a teaspoon, and again, the impact of lowering the blood pressure, 2 to 8 units. Physical activity, so regular aerobic physical activity, at least 30 minutes a day, most days of the week. Impact being 4 to 9 units of lowering of systolic blood pressure, and alcohol as well. So it's recommended to have less than sort of 14 units a week spread out. The other thing to sort of look at is just asking about what they might be sort of having in their diet. For example, if someone's having regular licorice consumption, that can result in very high blood pressure. Just going over type 2 diabetes. So the guidelines are looking at uncomplicated sort of diabetes, that is EGFR of greater than 45 and an ACR of less than 70. And the blood pressure targets for people with diabetes is the same as people without. There's no evidence to suggest that the threshold for starting treatment targets should be any different. If outside of these EGFR and ACR, then it falls into the renal guidelines. Same day specialist referral criteria. So it's going over the red flags. So if clinical blood pressure is 180 over 120 or higher, with signs of retinal hemorrhage, papilledema, which is swelling up the optic nerve, they both indicate accelerated hypertension or malignant hypertension. And looking out for life-threatening symptoms such as new onset confusion, chest pain, signs of heart failure or acute renal impairment, suspected pyocytoma, which is a rare tumor of the adrenal gland, and symptoms include palpitations, pallor, abdominal pain, diaphoresis, which is abnormal sweating. If there's severe hypertension, i.e. clinical blood pressure of 180 over 120 higher, but there are no signs or symptoms indicating same-day referral, then the advice is to carry out investigations for target organ damage as soon as possible. And then if the target organ damage is identified, we should consider starting antihypertensive drug treatment immediately without waiting for the results of ambulatory or home blood pressure monitoring. If target organ damage is identified, then repeat the clinic blood pressure measurements. If no target organ damage is identified, then repeat the clinic blood pressure measurements within 7 days and can ask for home blood pressures or ambulatory. In summary, we should confirm any clinic blood pressures with ambulatory blood pressure as first line or home blood pressure monitoring if that's not possible. We should check sitting and standing blood pressure to check for postural hypertension. Targets for type 2 diabetes are the same target as people without. Threshold for stage 1 without organ damage and a Q risk of less than 10%. And if the patient's under 60, it's slightly different from before guidelines in that we can offer them treatment if the patient wants it. Treatment pathway is more relaxed at stage 2. This is just to say that it's the blood pressure control that matters, not which medication is used, and patient decision aid can be quite useful at this. Referral to hypertension clinic if onset is less than 40 or resistant hypertension on maximum tolerated treatment. Any questions?
Brilliant, thank you for that. Has anyone got any questions? Please feel free to unmute or put in the chat. Whilst we wait, I do have a question.
Sure.
We were debating this yesterday. So what monitoring, if you've started on spironolactone as the fourth agent for hypertension,
Sure.
What monitoring would you put in place for bloods? Because the heart failure ones are quite intense on the monitoring.
Yes. So that's a really good question. I presume we would be following the spironolactone monitoring, as in it would need to be just the same as the heart failure thing, would need to be monitored quite regularly. But I think it's not something that I've because it happens within we normally refer it onto the GPs at that stage. So, and it's very rarely it happens. So, but I would need to look into that a little bit more in terms of, but I presume it would be similar level of similar frequency of monitoring, because you're looking for the heart failure is not really having an effect. It's more the kidney function that needs to be monitored. So I would advise following the same guidelines.
Got a question in the chat. Did you say that target VP for diab is the same for diabetic is the same for non-diabetic?
Yeah, so type 2 diabetes, uncomplicated within that range. The previous guidelines had lower targets and lower treatment thresholds, but since then it's been changed to, so as long as it's within that threshold as uncomplicated diabetes, we can treat them as same as non-diabetics.
What do you mean by uncomplicated?
So it's looking at the EGFR being over 45 and the ACR being less than 70. So based on those two things, it's saying that their diabetes is relatively well controlled, and they're not going to get sort of accelerated complications from the diabetes. So I think that the nice evidence when they looked at it, they showed that there was no impact on the mortality, etc., of having lower thresholds for those patients.
Brilliant, good question there. Have you had any interesting patients in clinic?
Yeah, so I think it is. We've found that a lot of patients at stage 1 hypertension, especially, it is because we've been doing quite extensive, seeing a lot of hypertensive patients. Found that if a patient does actually try to make the diet and the lifestyle changes, within 3 months, blood pressure is sort of even from sort of stage 2, 150. It's remarkable the reduction that you see just through sort of reducing the salt levels, cutting out alcohol, and adding in exercise. So it really shows that actually, if patient is very sort of determined and you give them the opportunity, the benefits of diet and lifestyle is sort of as significant as sort of adding in blood pressures. It's not for all patients, but you do find that over the scope of things, if someone's actually sort of putting a lot of time and effort into it, that the results are just amazing, really. Some people even don't realize how much salt they're having in their diet, and by going away just by making that reduction, it's been a significant reduction in blood pressure. So I think the small changes that I used to think that aren't going to cut it actually do make a big impact in it. So I think that would be sort of key thing to point out.
Brilliant. So Sam, who runs a technician clinic in Nottingham City, she said she's seen that too, like lifestyle for some patients can make a big, big difference.
Yeah.
Robin's asked, in those situations, how long do you arrange follow-up review to assess the response to this lifestyle approach?
Sure. So generally, I tend to do it at 3 months. And if it is within stage 1 hypertension, so less than 150 systolic blood pressure over 90, then I think we tend to give them 3 months. And if you have seen a reduction in the blood pressure within the 3 months, but it might not be quite there, then you can extend it as well. So quite often I've given patients, up to 6 months, and it's still continuing as well, sort of thing. So I think it's what you're seeing the outcome from. So if they have reduced by 5 or 6 units in the blood pressure, but they are sort of losing weight, because I think giving someone chance to lose sort of 10% of their weight, and if they have started to do it, it's an encouragement thing. So I think it's that adding on the encouragement for the patient, and it's perfectly at stage 1 hypertension. I think it's perfectly fine to give them as much time as they need. Important thing being that you are seeing the positive changes from it. At stage 2 hypertension, I think it's slightly. I tend to be a bit more sort of stricter and tend to limit it to sort of 3 months. If I'm not seeing a significant reduction, etc., then we will start to focus on the medication side of things to help to bring it down. But even at that stage, as long as it's come back into stage 1 hypertension, then they can still have a scope for carrying on that diet and lifestyle to manage it.
Brilliant. That's really good. And Sarah Kirkby has put, I like the chart of lifestyle changes, and I'll use that. And then there's another question from Adil. Thank you for it. Just to confirm, if patient is less than 40 years old and has a clinic BP of greater than 140/90, should we refer to the specialist hypertension clinic? And should we arrange any bloods or recommend any treatment before referral?
Sure. So if it's a clinic blood pressure of 140/90 and they're under 40, then what I would recommend is that we offer them either ambulatory blood pressure monitoring or home blood pressure monitoring. Once those readings have come back, and then if it is if it's 135/85, then that's very borderline, and I would double check with them. So for home blood pressure, ambulatory blood pressure, the targets change a little bit compared to clinic. So it's 135/85. If it's very, very borderline, it comes back as 136/85 or 137. I tend to double check how they did the measurements. So did they sit down for 10 minutes? Did they have a large meal? If they smoke, etc. So just making sure that they did do it in the right way, and quite often you can ask them to repeat it again. If it is hitting, if the home blood pressure, ambulatory blood pressure is close to 140/90, then I would recommend that we refer them to secondary care. Now that's based on my discussions with a previous secondary care consultant, Mark Glover, who advise us to do so. So we've had a bit of contact with him, and we keep in touch with him. And I asked him the same question: at what level would you expect a referral in? So he was quite happy to receive a referral at 140/90. And then obviously in terms of investigations, then yes, please order the investigations. There are other investigations, but they're going to look into that at secondary care level anyway. But the investigations are important because if there is any underlying causes, etc., they can be identified while they're waiting for secondary care referral. Hopefully that answers your question.
And how long is the wait for secondary care referral?
Unfortunately, it used to be very quick about 6 months ago, but we are finding that it's increased in the last sort of 6 months or so. I think that's because they might still be looking for someone permanent within the team at the minute, because there's been a change at that who used to be there before. So there is a little bit of wait there. They do tend to, what we're finding is that they do tend to look at the referrals and assess them quite, to see whether it's an appropriate referral. So, for example, with somebody with very high BMI, they might tend to bounce back to you and say the patient sort of to work on diet, lifestyle, etc. But so they do sort of have a little bit of a screening process for the referrals coming in, but the wait can be about 6 months at the minute.
I've just got another question, if I can.
Sure.
It's just about the management of the blood pressures as well. So with the patients that I've seen a lot of calcium channel blockers being prescribed quite a lot, mainly amlodipine going up to 10s or lercanidipine going up to 20s, and then they have edema as well.
Sure.
Would you recommend having medication at that level, or would you recommend, if appropriate, having lower doses of multiple medications rather than high doses of single medications?
Yeah, so I think it's a good question. Do tend to blood pressure control by using multiple medications can be really good because you're targeting different pathways of controlling the blood pressure. So obviously calcium channel blockers focus on dilating the blood vessels, and for example ACE inhibitors or ARBs focus on the RAS system. So it can be a good way of controlling by using combination of medications, and they're quite often, if someone is a bit resistant, then you do end up using multiple medications. If someone on, for example, you start them on 5 milligram amlodipine and they haven't got any edema, ankle or swelling, but at 10 milligram they do have it, then you have got the option of going back to 5 milligrams and then adding in sort of ramipril, etc., to their treatment option. So I do tend to. The tricky part becomes is that if someone is over 55, then ACE inhibitors or losartan become less effective because the RAS system becomes less effective in managing their blood pressure. So that's why it's recommended if they're over 55 to go to sort of calcium channel blockers. So that is that managing sort of different factors into it. So I think there's not one rule for everybody. So it's a combination of different things, but definitely if someone's got swelling on 10 milligram sort of amlodipine or lercanidipine, high dose of that, then try and go back to a sort of a medium dose and adding in another agent. Of course, if you have swelling at 10 and then you add in a ramipril, etc., that can deal with the swelling side of things as well, because it's getting rid of a little bit of fluid as well. So is that just working it with the patient sort of thing, and depending on what the blood pressure is and how the control is, etc. Maybe also thinking about diet, lifestyle as well in certain circumstances if it is stage 1 borderline hypertension.
Perfect, that's great, thank you.
Okay.
Thank you for that. Robin's put a good comment that from secondary care you can get some interim advice. So she had a young patient who was considering getting pregnant and they were very helpful. So yeah, they're very good at giving advice and guidance. It's just the wait maybe a bit long at this stage. Any other final questions? Do you use any other roles involved in supporting your patients? Because you said lifestyle is very important.
Yeah, so I think I'm very interested in social prescribing and that social aspect side of things and using a holistic approach. So I've recently been on a sort of a talk about that. So I think we're trying to add in looking at the social prescribing side of things, and it's something I'm working on within the team. I think we're quite lucky in that we're a specialized team that deals with hypertension lipids management. So we do have the time to actually discuss these things with patients, etc. So I think it's quite important. A lot of patients are very appreciative of the fact that you do give them the time and the options to consider all the other factors that they can work on, as well as not just going sort of straight to medication if there is sort of a scope there for it. So that's something I'm working on at the minute and trying to get that involved in there. And so we are actually, I think the other interesting thing is that screening for hypertension, we're doing a number of sort of pilot projects as well, where actually we're using sort of opticians as well, sort of thing. So we've got 2 local opticians that are screening for hypertension, and sending us in and following up with the community pharmacy. So if they do find a clinically raised blood pressure, they're sending it into pharmacies for ambulatory blood pressure, which is being sort of sent to us for management. I do think that we've built up really good links with community pharmacies, and we tend to actually offer ambulatory blood pressure through them as well. And I think they've got also an incentive as well currently in terms of getting ambulatory blood pressure done. So that's another avenue as well. So advise you to build really, get to know your local community pharmacies and build good relationship with them.
Brilliant. Thank you so much for that. Any other final questions? Otherwise, I think we can go away with a bit more of a refresher on our knowledge. Brilliant. Well, thanks all for attending. Hopefully next month's update will be on asthma. And hopefully we'll be releasing details of the dates on that soon. So thank you all.
Thank you. Thanks, everybody.